The 101st Airborne got there and actually whitewashed the entire roof of it and put a big Screaming Eagle patch on it. And they painted over all the Aramaic because they said, we don't care about these Muslims. And everybody went, yeah, this is a Christian place, dude. What are you thinking? So after that point, the chaplains took over and basically maintained it and kept it up and everything. And there was a whole planned excavation of it, and I guess they did, except they used dynamite. All right, I have nothing to disclose. I wish I was cooler than that. I don't have any money. This is what we're going to talk about. It's just the planning opportunities. I'll tell you what this is not going to be. This is not going to tell you how to handle a mass casualty event. You're going to have to figure that out by department, by what works for you and what the actual event is. What I'm going to try to do is hit you with the things that I've found, having done a few of these, what works, what doesn't work, and how to basically truncate your ATLS and your support of those critically ill patients down to the minimum so that you can move through casualties in a rapid fashion. So you think that, okay, this is Civil War. That's a mass casualty, right? It's coming off the battlefield. Basically, you get buddy aid there. You're going to lay there if you can get off the battlefield. The guys who didn't get off the battlefield are still there, so they're dead. So it's very similar to any other mass casualty to even have today in the civilian world. Well, we must be getting better, right? Because this is World War I. Oh, nope, still looks like crap. Everybody's on the ground. There's people laying everywhere. Nobody's really getting any help. All right, how about World War II? Nope, it still sucks, right? People are on the ground. People are being triaged and treated out in the open. There's not enough room. So this is a common theme that keeps going. But now we're in the modern age, right? So it's got to be better. Nope, we're still in the dirt. We're still taking care of people out on the ground. This is actually Nadja West. She's the current Surgeon General for the United States Army. She's a dermatologist by trade. Here she's just being a general medical officer, and she's treating an Iraqi casualty at that time. So we're still out in the dirt. So these are some of my friends. Regan Kwan and I were in residency together. He actually came to us right after his GMO tour with the Pentagon. So he was tasked by the commanders at the Pentagon to put together a mass casualty plan for the Pentagon. And he said, all right, this is what I'll do. And he goes, the plane or whatever crashes on the other side of the Pentagon. And they go, well, why is that? He goes, because if it crashes on this side, we won't have any medical assets. They'll all be dead. And so he deliberately made the plan so that he could not lose his medical assets and the people that were taking care of him. We're in residency, and September 11th happened. They utilized his plan, which basically saved hundreds of lives, and because that plane hit the wrong side of the building. So put that in your conspiracy theory head. I went, really? So they knew that's pretty interesting. But yes, he actually was involved with that, so it's one of his things.
He was involved with the plane crash?
Well, no. He was involved with, well, you never know, though.
Yeah, because
You never know. Simon Tillian, he was in Mosul in 2003. There was a bombing in the Chow Hall. He had 93 casualties instantaneously. He had them all triaged out on the ground. He had another surgeon and another orthopedic surgeon. That's all they had, 2 ORs, trying to go through all these patients. They then got mortared, so all the patients got thrown inside. So all that triage that he'd done, where he would set everybody up to who's going to go to the OR and when, went to hell. And so he had to re-triage and basically operate on people as they're going. The big thing I took away from him is that he had 14 people that met criteria by ATLS to take them to the OR for thoracotomy because of how much blood came out of their chest when the chest tube was placed. None of them could go anywhere, and they all lived. So what that really tells you is maybe that criteria isn't so great after all. And having seen it multiple times, I can tell you a lot of the times you just wait and they're going to stop bleeding, or they're going to bleed to death, and you won't have enough blood to take care of them anyway, so it won't matter. Pat Cook, he was with one of those guys that must not be named on an outpost in the middle of nowhere. Mortar round came in. He had 22 casualties right there. He was the only medical guy at all, so he was trying to take care of all these people. And then Eric Gorley, he and I, these guys were all residency together. Eric Gorley was at Fort Hood, chief of surgery, when Nadal went through. Is it Nadal? He went through and shot everybody. He said the biggest thing he had was a lack of accountability. He said it was we're 2009. We have a lot of experience doing mass casualties. We have a lot of experience with the operation or operators that are involved, and they couldn't keep track of x-rays, and they couldn't keep track of labs, and they couldn't line all this up together. And so that was the big thing he found. So what I've done, my first mass casualties in 1991 when we invaded Iraq the first time. There was a little known thing that went on there, Al-Nasiriyah, which is in about the tail end of the country. Uprising, they started shooting everybody in the street. They went through. So all we got, these 34 casualties are all women and children. So none of the men made it out because they executed the men. They just shot into the kids. We took care of those. That was my first exposure to it. I think it was 21 at the time. 2007, I was in Mosul again, and this time they blew up the Yazidi village. We had 29 patients come in by Chinook, so that means 15 landed at one time, so you get 15 at one time. And then we went on from there. We did have 3 surgeons. We had 2 ORs to work with. We did have 1 hand surgeon. So basically, you just go through it and re-triage, re-triage, re-triage. April 10, I was in Shindam, which is close to the Iranian border. I had a 2-person mass cal. So this is when you get to the point where, what's a mass cal and what does that mean? Well, if you're the only surgeon, the only guy there, and you have 2 people come in, you got to make a choice who you're going to take care of. And one of them had a significant head injury, and the other guy was screaming. I declared that guy dead or expectant and went and took care of the guy who was screaming. The last one, this is when I was in my last deployment I've had with the Army. We were in Coast Afghanistan. There was a big military-grade explosive. It killed over 50 people at the scene, blew the, what we call a T-wall in half. Big explosion, blah, blah, blah. I walked up to the clinic area after we semi-secured the scene, and there was a parking lot full of people, and there were 7 people in my trauma bay for 3 people that's only meant for 3. I'm the only surgeon here at all. I have nobody else. There's 22 amputations, burn, blast, penetrating trauma patients, no bullshit trauma. And you go, what the hell am I going to do? This is out of Jennifer Gurney's paper. She just published it from the JTTS. It talked about the workload that we had in Afghanistan. I was deployed then. Highest workload ever in Iraq. I was deployed then, highest workload ever in Afghanistan. Just to give you a clue, if anybody's seen Baghdad ER, which is a great movie, that was 2004, that's them. So we were doubled what they did. And so it was just a constant mass casualty. So we're getting 15 patients out of whack, and you were just operating. There's 40 some odd cases going every day, and it was all trauma. And then the last one, I'll take credit for that one too, because we were the only one producing casualties, because we were the only one doing kinetic activities in Afghanistan when I was there. All right, so why do we care? Big splurb of bad crap going off in the world. Well, what's that? Boston Marathon, right? The bombing. So this is just that picture right before all hell broke loose right there. And this is an improvised explosive device. That's what we have experience with now. You can take anything you want, put it into a can, load it up with some ball bearings, nails, screws, and use it as a device to wound. They're not powerful enough to kill most people unless you're right on top of it, but it is going to distribute those wounds out, and it's a terroristic weapon. This is another horrible busy slide. Shouldn't be this busy. I'm a big gun guy. I love guns. I shoot them, but I also believe that we should have some sort of gun control, because this is getting ridiculous here. These are all the shootings that happen, and so it's something that you could run into at any time. What makes you different from Sandy Hook? I don't know. We'll have to see. And then we come to our glorious state. We're going to say, why do we care about mass casualties? Well, we'll put that first one up there. Guess what that one is? Anybody want to guess? What is it? Barksdale. Barksdale has aircraft, right? They also have nukes. I bet you didn't know that. Hopefully, if they do nuke us, it'll be quick and we won't know it. But there's a chance of nuclear, plus there's a big depot for explosives. There's another one. It's by Minden. That's the Army depot. That's where we have all our rounds, too. Another possibility of having a mass cal. Lake Charles, what's down there? Refineries. So if you're here, they're there, they're going to be coming to us too. Because if they overload those patients, overload those other hospitals, you got to be prepared for that. And then there's one last one. It's actually in Arkansas. I put it at the top of the booth. It's called Pine Bluff. It's where we have all of our chemical weapons. Mustard gas, white phosphorus, all the stuff that hurts people badly. Theoretically, we're destroying it. I don't know. I don't have that clearance. But that is just right up the road. So you have plenty of opportunities to create a mass cal all over this. So everybody goes, oh, well, we're really safe here in the middle of the country. No, you're not. All right. So the question to ask yourself in your department is, how do we prepare to take care of the community in case there's a mass casualty? And how do we flex the focus of the hospital from a medical patient to a surgical patient? So we have the luxury in the military of having combat support hospitals. Nowhere does it say anything about support medicine. It is all surgical based. The whole thing is based around surgical interventions. Who needs training and what training do they need? For us, we always, I look at when I'm doing 22 patients worth of, mass casualty, I'm not doing anything. I'm telling people to do things. Because if I engage in a patient, I'm not going to be able to take care of them. That means that medics, nurses need to know how to put in a chest tube. They need to how to put in a central line. They have to be elevated in their ability to care for patients. And everybody goes, well, it's out of their scope of practice. Well, I'd rather have a nurse put a chest tube in me out of the scope of practice and save my life than watch me die because she can't put a chest tube in because somebody said so. So you have to be able to flex that out and go, how do I train them and who do I train and what do they need to be trained on? Also the quantity of the personnel. Oh, dang it. And how do we utilize them? So again, we have to flex. The big push is going to be in the ER when it starts. The big push will be to the OR and then to the post-operative and in the ICU. So you have to be able to flex that manpower in and out of there. So if you're an ER nurse, it doesn't mean you just get to be an ER nurse today. You can be an ICU nurse. You can be whatever you need to do, but you have to have a complete flux and flow throughout that hospital. And that also accumulates, or that knowledge will accumulate and be able to be used in a mini mass cal. Let's say you get 5 patients in the ER, flexing back and forth and making sure that your nurses can actually care for people. So our standard model for trauma, good guy gets shot, bad guy gets shot, whoever it is. And then we have a surgeon, an ER physician, an anesthesiologist, a nurse, another nurse, a recorder, a lab person, pharmacy, radiation technician, a couple of residents hanging out there, all for one dude. All right? So the question is, what do you do when you have 5 dudes? How do you break those people up? I can't tell you how to do that. That's what the ER needs to figure out on their own. That's what everybody needs to figure out on their own. But what happens if you get a few more? Oh. All right, that's 22. That's what I had to look at. Just me. Believe me, when I walked up, I may not went, F, let's get to work. So what do? You flex you got to break that mold. You have to be able to tell people you're not assigned to a bed, you're not assigned to a patient, you're assigned to wherever the need is most, great for the people going through. The ER flexes people in and out of the ER, the OR, the ICU. We routinely pulled people out of the ER to make them run to Belmont when we're in the operating room because we didn't have enough people. You routinely take the nurses out of the ER and send them to the ICU to take care of patients who are intubated and on basal active drips. So you have to be able to flex this in and out. So protect your resources. Everybody forgets about this too. So when we had the bird flu scare, the military sat down and wrote out plans. Their very last step of their plan was, you're going to put up roadblocks and you're going to actively shoot people who try to overwhelm your facility. So there's a lot of stuff that happens during that because people start dying at home, or dying in the street, dying in the hospital, and it's a bad day because of the overwhelming infection. So you got to protect your resources. And the way you do that is follow what they did back in the Napoleonic era. You go ahead and triage them, you get their litters, and stuff that's going on. Letterman is the big guy who decided to actually get patients off the battlefield and then put them into the hospital. There's a hospital that was a great hospital. It was in Presidio, California. We gave that up. We're idiots. We kept Fort Bliss, but we gave that one back. And you can look at whatever book you want. NATO's got a book. Everybody's got a book. World Health Organization's got a book. But usually it breaks down to immediate, delayed, and expected. All right, don't waste your time on expected. If they have a gaping gunshot wound to their head, don't even try. Just move them off to the side, focus on everybody else. If everybody gets through with that, then you can go back to the head and then try to take care of them. Immediate patient, somebody who's got a gunshot wound or an active bleeding to the leg, you throw a tourniquet on them, now you've moved them from immediate to delayed. Now you can wait on that guy. You can sit on him. So your immediate should literally be, for operating time anyway, non-compressible hemorrhage. That means gunshot wound to the abdomen, gunshot wound to the chest, the neck. Someplace where you can't actively hold pressure on it and stop the bleeding yourself, that's the person who is immediate. Everybody else we should be able to deal with our adjuncts that we have, like combat gauze and tourniquets, etc. This is a continuous process. You may have put somebody in delayed. Now they look bad. Now they're back to immediate, so you need to take them to the operating room. And believe me, I've sat on more gunshot wounds to the abdomen than I've ever thought I would in my life. Any patient in the States, I would say, needs to go right to the operating room, and you put them in the ward if they're awake, you put them in the ICU if they're intubated, and you wait for the ORs to come open, and then you take them to the operating room. And this is my rule. I'm not the originator of this, but if you want to throw rocks at somebody, you can throw them at me. 80% of people, you won't have to do anything to. I mean, that's clean them out, give them a hug, send them on their way. And again, that goes to protecting your resources, because everybody's going to want to come to the ER, and everybody's going to want to be treated. And if they're walking and talking to you, they can hit the road, because we're worried about this 10%. This 10%, we're going to try to help, but no matter how good you are or how good you are at triage, you're going to take care of 10% that die, because that's what happens. I wish I was better at that too. And what you really need to do is make a simple plan that makes sense to get your job done, because there's problems with expectations. So this guy, he's out there munching grass on the side of the road. He's walking out there. Next thing you know, he sees you. He looks up. He goes, "What the hell?" And the reason he does this is because his expectations aren't being met. So he's in the grass. He's enjoying himself. It's a nice evening, cool breeze blowing. And then Dr. Rudd comes in his four-wheel drive truck and is going to run him over. And he's like, "Oh, what the hell? Where'd that come from?" Well, that's the same thing that happens with people. And I'll give you a good example of this that happened to me. One of the last cases I had before I came to work here. They were doing an EGD on a preoperative gastric bypass patient. The patient, they oversedated it. The anesthesia, the CRNA started to panic a little bit. Give me the glide scope because they're obese. Looks in the glide scope. The glide scope, somehow the optics had been turned sideways, so he was seeing the airway on a different angle than he's ever seen before, and his brain couldn't wrap that around it, so then he just lost it completely, and it just went to crap after that. She was okay. We did have to do a few rounds of CPR, but she was all right. But it was just because he knew what he was going to do. It didn't work. His fallback gave him something he wasn't anticipating, and then he froze, and then he lost his mind. And everybody will have this happen to them. So you need to be able to walk in there and go, okay, I'm not going to have my expectations met. I'm going to be overwhelmed. It is going to be horrible. Let's just keep moving on. So when you see stuff like this is what you're going to see. You're going to walk in and you're going to like, oh my God, that's a bilateral amputation. That's Afghanistan. I can tell you that because that's the high-powered explosive devices that they were using were used to kill MRAPs. Well, this is a dismounted soldier that took off both legs. It's the classic injury that happens. He has an open pelvic fracture as well. You can put your fist right up into his peritoneum. This is an Iraq. This was designed for wounding. There's screws, there's fragments, there's everything else in there. Lower velocity, usually a single amputation. So you walk in there and you got people like this laying all over the place. Do not just be expecting that this is going to be bad and I should feel bad and this is nasty, and just move on from that. And then you get to the point like this, where this is the OR in Bastion, And there's 4 operating rooms running simultaneous with all trauma patients that are going. One there, one here, one there, and there's one in the back that you can't see. And you can imagine this whole beehive of activity. It's very chaotic. You know, keep track of your patients. You'll run into things like this. That's me. That's Graham Sunderland. Graham Sunderland's from Edinburgh. He does not believe that masks decrease infection rates in operating, so he refuses to wear one. I said, okay, Graham, you do what you want. I'm going to put all this on so that doesn't get on my face because that makes me icky. But this guy was this was a wheelbarrow bomb rolled into a place in Lashkagar, blew up in the market. I got this kid. It took out this whole chunk right here. I had to do a superficial femoral artery repair on him, fasciotomies, etc. All right, so this is abbreviated to ATLS, which we all came for. This is where the surgeon gets to tell you you don't have to do all that stuff on that checklist. So there's only 4 things that'll kill you right now. And if anybody can think of another, I'd be more than happy to entertain your idea. Is anybody? Yeah, it's not going to kill you. You're going to bleed to death. Yeah, failure to recognize. So now the question is how do we recognize these 4? And that's the big thing that you come down to is like, how do I recognize these 4, and can I do that in an expeditious fashion? Sorry. So if I give you 25 patients, lay them out on the ground, how are you going to do this? All right. So primary survey. What do? You kneel down, you grab their wrist, you feel for a radial pulse, and you ask them, "Hey, dude, what happened?" If they can talk to you, that guy's going to be. You got a little bit of time on him. If he can't talk to you, you can't feel a radial pulse, then that's somebody you need to go to the next step on. I believe in the ABCs. That's exposure. Strip this patient naked right now. Don't worry about his airway. Don't worry about bleeding. Don't worry about anything else. Strip him naked. Find the wounds. All right? The next thing you do, stop any active hemorrhage. Put on a tourniquet. Plug a hole. Put on pressure. Worrying about this airway is not going to kill this patient. They're going to exsanguinate before you ever get to that point. So there it is. This is what I do. This is how we always ran everything. We were running 10, 15 of these a day. You were just did it the same way every time. And then you won't miss stuff. And you won't roll somebody over and find out that they have a hole the size of your fist in the back. And then you're wasting your time by doing other stuff on top. Strip them, roll them over, get a good look at their back, make sure there's no other penetrating or anything else going on. You can get a chest x-ray, get a chest x-ray. If you can't, use your EFAS. We now have this portable, ultrasound. You go out there, and that's what I did on the last mass cow. We ultrasounded, fasted them real quick so that they could get on a helicopter, and I knew they could make it 30 minutes to the next place. And then you worry about your ABCs, all right? If they need to be intubated, you've got this whole thing takes maybe 30 seconds, all right? You're not going to kill anybody by not having an airway for 30 seconds. But you will kill them if you let them bleed to death while you're worrying about their airway, okay? And now we talk about the tension pneumothorax. Well, how do we figure that one out? Well, we're going to get a chest x-ray or EFAST, all right? Put a chest tube in. If you don't see lung markings, put a chest tube in. If you have decreased breath sounds, put a chest tube in. Don't even worry about it. Don't contemplate it. Just put the chest tubes in. All right, so what about cardiac tamponade? Cardiac tamponade, well, muscle or muffled breath sounds, or you can put a ultrasound on it, which is a great tool. You can see it. Does he have fluid? It does. Throw a needle in it. Do a left lateral thoracotomy, open it up. What about obvious hemorrhage? Put the tourniquets on. If you have a non-compressible hemorrhage in the groin, what are you going to do, Dr. Rudd? You go to the OR. But you can put your knee right into their groin and just kneel on it. And that'll save them for a little while. You can ride up to the OR with your knee stuck in somebody's groin. It's the only time you get away with it. And then the last one's the airway. So what do you do for airway? Well, crike, right? So these are the things that you really need to know how to do. This takes no time, no effort, no skill. Put this on. We teach 18-year-old kids who played nothing but Xbox their whole life and teach them in 6 weeks how to be able to do a tourniquet and do it appropriately. Tube thoracostomy, even if you just stick a needle in their chest, if you just make a blowhole and stick a 10 blade through the rib cage so that they can evacuate that air, you're going to be okay with that tension. If you can't get an airway in it, or you're not good enough to put an airway in, as far as doing a direct laryngoscopy, do a cricothyrotomy. Better to have an airway than a dead patient. Pericardiocentesis, you got an ultrasound, or you just blindly stick it. That's how we used to do it before we had ultrasound. Everybody forgets about this. When I say you strip a patient naked, you strip them naked to nothing. And then you throw a blanket on them, please, because it's nice to be warm. And another thing they can do is blood administration. Now, we were testing a new concept where they wanted to take a 6-man team, put it forward on the actual, like the forward edge of the battlefield for where the troops are in contact. So we could do emergent surgery to try to cut this golden hour down and try to increase our night, because we're like at 96% survival, and they want to get that last 4%. But you know that any graph that says the last 4% is exponentially hard to get to. So they decided we're going to put a surgeon in everybody's rucksack. Well, that means I have to go out to the front line and get shot at, which I'm not real cool on. And what we found out was we can just take ER physicians or highly trained family practitioners, give them blood, and they can do the majority of the saving up front. They don't need a surgeon up there. What they need is ATLS, because I'm not going to do something horrendous up there. If you crack somebody's chest, 20 miles out from a hospital, you're not really going to do them any good. I could do it, but should you do it? And when you go to the operating room, you got to triage for the OR. And that's why they said the most senior surgeon should be in charge of the triage. I don't care who lets the patients in, but somebody should be blocking all those people that say, if I can talk to you and I'm walking, then you need not to be here. But once we get to that point where we're going to operate, somebody's got to go through, keep track of who we're operating, and go number 1, number 2, number 3, number 4, and hold off as long as possible. What you don't want to do is go, well, got a gunshot wound in the abdomen, woo, I'm off to the OR. And the next guy comes in, it's got a gunshot, through and through his pelvis that needs to go right now to get everything ligated so he doesn't die. This guy, the first guy he took, has a through and through to his colon, no big deal. You're like, I'll just resect that and we'll be all good. So hold as long as you can and then go. But if you have somebody who's emergent, like somebody who's actively dying in front of you from non-compressible hemorrhage, take them to the operating room. Don't wait for that. It depletes resources. You're going to go through a crap ton of blood. You're going to go through everything else that's the OR burns up. So it's not the end-all, be-all. This is only about 10% of all the people that come in for a mass cas, but this is what you're going to be doing. It depletes the heck out of your manpower. For every surgeon that's in the operating room, that means you have one less provider who's able to do ATLS on the outside. It also means that you have to have a nurse, you have to have a scrub tech, you got to have anesthesia, you have to have all these other people to assist that surgeon in the way that it's for the procedure of the operation. The other thing that you want to do is abbreviate procedures. We talked about damage control. We usually damage control patients when we think that they're too sick to go on, like put valve back together. We call this something like tactical damage control. That means I don't have enough ORs and I have too many patients. So what I'm going to do is stop the contamination, ligate the bowel, whatever I'm going to do, and that patient gets thrown out of the operating room, they go to the ICU. Then we bring in the next one, do the same thing. We'll take those patients back in a day, put them all back together. It's not a physiologic cause, it's because of a lack of resource cause. And so you have to keep moving those people through that process. You've got to move the meat, is what we said. Remember, during a mass cal event, your expectations will not be met. I can tell you that all the guys that I showed you before will tell you that's some of the worst memories they have of their life is because they walked right into it and they weren't ready for it and they were just like the deer in the road and they go like, how did this happen? And what did we do? And I can tell you that I was the same way. I thought I stood there as I'm looking in the trauma bay that was big with blood everywhere and people laying and writhing and I thought for, 10 minutes just staring there going, what in the hell am I going to do? Which really wasn't 10 minutes, but it felt like it. And then you just go, okay, what do I do? Start doing ATLS, that's what you do. Stay out of the operating room. protect yourself and the resources. That even goes down to if they're coming out of a chemical plant, if they're coming out of a Barksdale with fuel. Those patients are contaminated. They got to be cleaned. If they're coming out of any issues with explosives or anything else, you got to make sure that they've been screened before you get to them. Because we kill us, then nobody has us. So we're kind of a big deal. You can use this if you want. I don't really care. That's how I prefer it. It's the quickest way to move through a bunch of people and make sure you don't miss anything. There's been many a time that everybody does it once where they go, oh, this guy looks pretty good. It's not anything bleeding. Hit him with your first 2 units of blood. The blood pours out on the ground, and you go, holy crap, this guy didn't have any blood left. That's another thing. If you see a wound that's not bleeding, and it should be, it's not because they're hypotensive. It's because they don't have any blood left. All right? There's a difference. Hypotension, no blood. No blood we can fix. It's one of my pet peeves. And again, think about abbreviating the surgery for tactical purposes, and then hold off on the OR as long as possible. And that's something that the senior surgeon should be able to make the decision on. The most important thing is debrief your people. I can't express the need for the psychological outlet, because for me it's not a big deal. We do it. We're going through it. We don't have a problem. But you'll have 18-year-old kids that have never seen this before, never seen a dead body before, and they're helping you. And if they don't have an outlet of, you did everything you could, great job, let's talk about things that went well, things that didn't go well. And in that point in time, you go, hey, let's talk about what we did well. What did we do good? You did a really good job on that chest tube on that patient. You really did a great job. You don't tell them that, and then you pulled out a central line by accident, and so we had to stick them again. You don't bring up the negatives, bring up the positives, reinforce that. Let them vent. People who get PTSD from this are the people that don't talk about it and don't talk about their combined experiences. And that's the other thing, you'll get PTSD from this stuff. Always the positive things. Make them think of three good things. Make everybody say something that happened. Everything good. What happened? What was good? And then discuss the negatives a little bit later. Wait for everybody to kind of digest it. And then be willing to refer your people to the necessary counseling that they're going to need. I had 2 soldiers from that 22 mass cal injury or issue that ended up going on to needing additional psychological care just because of that incident. And this is me. I'm really cool. See that right there? Look how cool. I have a gun sitting on a C-130. What you really don't see is that this is 118 degrees sitting on the tarmac in Bagram, and I'm sweating so bad I just want to die. This is me trying not to throw up and pass out. So this is Major Godessa. He was my ER physician. So I'm not allowed to travel anywhere in the theater without an escort because we're too expensive to replace and too important. So you're not allowed to go anywhere. You're treated like glass. So I had to have my escort. And somebody took this picture, and I was like, oh, my God, I'm going to die. But, yeah, it's one of those. I remember the day. It's even got the date time. All right. And that's it. Any questions about that, please? It's supposed to be interactive. Sir.
Really enjoyed your talk, but I have a question, and a reason why I'm asking is, I'll give you that as well. Now, there are many people who are not in these scenarios, and they don't do this, even they're surgeons, non-surgeons, but they act as Monday morning quarterbacks. Is the PTSD we all have, what is your advice how to deal with those kind of people?
Well, and I would hope that you'd be able to. We had the same issue. We would go through something like this, and I actually, for the 22-patient mass cal, I was actually attacked by the theater, and it wasn't necessarily the boss that I was evacuating to, so I was out in Coast. Bagram was more central. I sent patients there, and they were saying, well, maybe they should have, why did you overfly? I said I didn't make the decision to overfly, but I was getting questioned on why I sent these patients without doing a thorough evaluation. And I'm like, well, I don't know, because there's 22 frickin' people here we're intubating 15 at a time. We're loading them up with ketamine. I'm trying to get lines put in people, and what it came back to is that they just want to make sure you're doing the right thing and it's safe. And if you haven't been and I immediately got very defensive and started yelling at people. And I told them they more than likely have their job if they'd like it, and they could come out here and do this, and I'll go sit there. But I don't have a good one. I
I really like your slide of debrief, find positives, discuss negatives. But I raise this question because I see more and more in even academic surgery, like in our environment.
Yeah.
People are not there. They are just want their voice to be heard. So I just was curious, you have any recipe for that?
Yeah, I don't. I just get mad. Then I stomp off to my office. I wish I was more eloquent. All right, there's got to be other questions. Sir.
I think, the thing that surprised me is that, none of these hospitals in the civilian, theater is ready for any kind of mass cancer. Even, and I keep saying over and over and over, no matter how you describe your level 1 process, if the buskers have the road, you're not going to be able to take care of that. There's no preparation about that. So in my modest experience in Europe and so on, I must admit that, we were a little more prepared somewhere. And hospitals in critical areas had, already prepackaged, let's say, a scope to intubate people, all kinds of different things. It's interesting that, you have, soldiers, the U.S. soldiers have more tourniquet on their uniform than the American soldiers. That, for instance, the British soldiers or the German soldiers. But for even in Israel, you can have a mass gathering, that's pretty often, with bombing and so on. First thing that happens, that one, they call everybody back to work. Two, they open the cafeteria, they throw away everything, and they put patient there on the cafeteria. And they have 2 surgeons or 2 nurses for each patient. That's all. That's the other thing. When we used to have bombing in Europe, that was the idea. Here it is not. I don't see that. And it's not here. We get the communication. I remember Houston or Detroit. Only when the president comes around, the president lands close to you, you are supposed to be, ready to act. And usually it's just the administration, and they call you and say, John, be sure that
Yeah, it was fun. So the drill that they run is the Secret Service vets, a trauma surgeon, and then you actually have to sit in the hospital, in the ER, with the Secret Service, with a OR cordoned off by Secret Service, an ICU bed cordoned off by Secret Service, and an emergency room cordoned off by Secret Service. And Secret Service are congenitally absent humor. They are the most, it's just, I don't know how to describe the experience. It's just can't wait for Wheels Up, for them to go away. We have had many mass casualties here, and I think your perspective is actually very elegant, and that is a mass casualty is anything that overwhelms what your system is normally used to taking care of. So in this case, it was a poker game gone wrong, and we had 5 gunshot victims simultaneously. Now, that's not anywhere close to 22 that you had, but we were able to mobilize. It was Yusuf and Dr. Samra and myself at whatever, dark 30 in the morning. And the reality was, think only one of them really needed an operation. Is that right, Samra?
Yeah, one we triaged had to go to the operating room.
But
One you said was dead. Was
And a lot of what we found is that ATLS is what you do. Airway breathing, circulation, stop the hemorrhage, take care of the patient, give them some blood, and usually those patients will be fine. It's only the 10% or less that you actually operate on.
But I have another question, maybe is for our colleagues. Do we have a mass casualty call schedule? Like, suppose
Yeah.
I know we have a backup person.
I don't.
Everybody's cell phone, that's
Yeah.
the mass casualty
Just
call
come.
schedule.
And again, everybody would be on it, so you'd have to call everybody.
We can call our general surgeon colleagues as well.
Yeah, everybody.
Who take
So,
good care of
two experiences with that. One was the Loma Prieta earthquake, where they just called everybody back.
all the chief.
It was in the region. That was the earthquake that hit during the World Series. For those of you who are old enough to remember it, I don't remember which World Series it was. It was Oakland versus the San Francisco Giants, and it was right before the game was supposed to start. So the last big earthquake that hit the area.
2002.
88.
88. Oh Lord,
Yeah.
it's high school.
Sorry. All right, I'm getting old.
But no, I don't think anybody is. Again, it's all incumbent on. You cannot prepare for mass cal. I don't really care. I'm going to be here. I'm going to take care of patients best I can. But the hospital in general needs to be able to flex up and take care of it. And I've had 5 gunshot wounds here, and you run out of nurses really fast because the culture was, well, I'm assigned to this bed, I'm not going anywhere. Well, we need to break that culture and organize so that we have the freedom to flex and move around, and you just gotta be flexible, semper gumby, and all that good stuff. Any other questions? All right, we'll stop the madness. All right, thank you guys, appreciate it.